Hello, my name is Jane Apperley, and I am a haematologist from Imperial College in London. And I have a particular interest in chronic myeloid leukemia, as many of you listening will know. This interest has really been across my career in haematology because I started many years ago being fascinated by bone marrow transplantation. And some of the older people listening will remember that in the early days, the main indication for allogeneic stem cell transplant was chronic myeloid leukemia. And of course, at the time I started, we restricted the age of patients that we transplanted to probably less than 40 or less than 45. This meant that when we were transplanting individuals, we were often transplanting them at a time in their lives when they might have been very keen to start or extend their families. And we were using total body irradiation at that time. So it meant that both men and women became infertile after the transplant. And we started then to look at ways that we could preserve fertility in patients who were destined to undergo a transplant for CML. Now, obviously, things have moved on very, very considerably, but this interest has stayed with me. And it's been a fantastic journey for me in my professional life, an enormous privilege to be involved with chronic myeloid leukemia, because I've seen it change from this disease that for people over the age of 45 was really a death sentence, to a disease that is a chronic disease that's very easily controlled for the vast majority of patients, as long as they remember to take a single tablet each day. And their life has essentially returned to normal, and they can start planning their lives and their careers and their families and their expectations in such a different way from when I first started that it's been fantastic to observe. But with the tyrosine kinase inhibitors and the ability to give people a normal life expectancy, we then have to address the problems of living with a disease and trying to manage your life around that disease and its medication. And one of the issues that came up very early in the advent of TKIs is what we should do about patients who wanted to have children. And by that, I mean both men and women. And for several years, at the beginning of the use of tyrosine kinase inhibitors, we continued to store sperm on all men who were recently diagnosed with chronic myeloid leukemia and were about to start treatment. Now, I have to say that it's still a bit of a debate as to whether we should continue to do this. We at the Hammersmith, where we're very privileged in the West to have very good facilities and a national health service, often do this for men who have not yet started their families and want to do so. And Dr. Yassin is going to discuss this with you in considerably more detail in relation to men with CML. The general expectation is that men with CML can continue on their TKIs without compromising their fertility and shouldn't stop them while they're trying to conceive a child. There has been a paper from Frank Nicolini suggesting that the quality of the sperm might drop off over time, but this has not yet been validated, and I think it's still reasonable to ask men to continue their TKI. But Dr. Yassin will give you far more detail about that. Of course, the other issue is women. I shouldn't say the other issue is women, but women are a major concern because, as you all know, taking the tyrosine kinase inhibitors during pregnancy, particularly during the early stages of pregnancy, is unfortunately associated with congenital malformations in the babies. So this is something we want to avoid at all costs. And there are at least 3 situations for women with CML. One is that some women will present with their chronic myeloid leukemia during a pregnancy, because for many of them, this will be the first time that they've had a blood test. And so they go for their what we call a booking appointment, and they have a full blood count and their white cell count is high. And then there's a big dilemma as to what to do about this. Now, fortunately for most of these women, the white cell count is not very high, otherwise they would have had symptoms and the pregnancy could be managed without intervention. But for those women who do need treatment or do need an intervention, it is a problem. And I know that Elisabetta Abruzzese will deal with this, as our colleague Ekaterina Chelisheva has just done a very large survey of what happens to women who present in pregnancy. Then the other situations are when a woman has established CML, she's been on a TKI, and she would like to have a child. Now, that might be an unplanned pregnancy where she suddenly finds that she is pregnant and has been taking the TKI at the moment of conception. And the question then is what to do. And of course, what to do depends on how well she's responded to treatment at that moment. The better situation, of course, is when the woman has established CML, has been on treatment and is responding very well, and wants to discuss with you how to go about becoming a parent. And then this can be relatively easily managed, particularly now that we have all the information coming from patients who have stopped their TKIs, irrespective of wanting to parent a child, in the context of trying to attain treatment-free remission. Now, of course, I'm speaking from as somebody who works in London, where we have very good facilities with respect to molecular diagnostics, and we can monitor patients very easily with RQ-PCR. I am acutely conscious that this is not the situation in the rest of the world. And it's very easy for me to speak about stopping a TKI and doing a PCR every month and intervening if it should be rising and the patient needs to restart treatment. It's very different in many parts of the world where many individuals are still managing patients largely on blood counts. This will be addressed by Amma, who is working in just such a situation. Where she's trying to manage women who want to become pregnant in resource-limited situations where you don't have access to molecular monitoring and you have to use your clinical experience and good judgment in helping women cope with this situation. We will touch on very briefly the woman who presents in advanced phase and is pregnant, where the situation is rather different, and we would probably recommend termination of the pregnancy. And similarly, in a woman who is really not doing very well on their TKI and wants to become pregnant, this is probably not a very comfortable situation. This is obviously a big subject. It's very different across the world. We manage in different ways. We should all be trying to manage in ideal circumstances, although I know this is not possible. And I think, will be very interested in your feedback on this session to see if you found it helpful or whether there are areas that we did not address that you would like to see addressed in future sessions. So enjoy the session and hopefully it will help you manage your patients with a little bit more experience in the future. Thank you for listening.